All right, so let's do the same pattern. So we'll talk about the disease first. What is it? What happens? Who are at risk for getting it? Signs and symptoms of those who got it. How do we know? Meaning diagnostic testing. And then we'll go to treatment. Treatment will involve pharmacologic and non-pharmacologic. So what is COPD? There used to be 3 COPD. They were chronic bronchitis, emphysema, and asthma. Asthma is no longer a COPD disease. It's now a allergic disorder. So that's why asthma patients are under the care of an allergist. Okay, they can still be under the care of a pulmonologist, but most of them are under the care of an allergist, okay, because they change the nature of asthma. However, in this chapter, in this textbook, asthma is still under respiratory conditions, but technically it's an allergic disorder. So we're down to 2 now. We have emphysema and chronic bronchitis. Acute bronchitis is not COPD. Acute bronchitis comes and goes. It's treatable. COPD, which is chronic bronchitis and emphysema, are incurable. All right. So this is a chronic disease. People learn to live with it. They can still live relatively normal lives with exacerbations, just like heart failure. So let's go to each one so that we can distinguish the manifestations. Okay. So there are 2 possible causes of COPD. Number 1 is smoking or any exposure to air pollution, for instance. So let's say you work in a factory with a lot of dangerous chemicals that you inhale, say involving aerosolized particles, for instance. So that's just like smoking. Okay, so your lungs will get damaged in the process. And the other is an autoimmune disorder, meaning the patient is deficient in a certain enzyme that leads to COPD symptoms. Okay, let's start with chronic bronchitis. So again, not acute. Acute bronchitis comes and goes, it's treatable. Chronic bronchitis, however, is not. This is COPD. So this type of COPD affects the lower, affects the upper airways of the patient. So this starts from the mainstem bronchus all the way to the left and right mainstem bronchi. So what happens here is, because, again, we'll use a smoker as an example. So what happens is when you smoke, can you smoke 24 hours a day? No, people have to sleep at some point, right? So the smoker, let's say, smokes for every waking hour. So that's what, about 16 hours a day? So they smoke. So what happens is, all this debris that they're smoking in, the smoke, the nicotine that enters the lungs, causes inflammation of the airways and hypersecretion of mucus. If this is multiplied by months, years, decades, what happens to the size and activity of the mucus-producing cells, these goblet cells? What will happen? They will increase in number, and not only in number, but also in size. So can they stop the increased production of mucus once the patient stops smoking, let's say goes to sleep and doesn't smoke? Can they stop the production? No, not if they're already very hyperactive and there is already hypersecretion. So that leads to the patient's symptoms. So this will lead to increased mucus production. So very thick mucus. And if you subject the patient's upper airway to this amount of mucus, what happens to the cilia that normally propels the mucus upward? Like you and me, sometimes when we wake up, we have phlegm, right? And then we can easily expectorate that. We go, and then we can easily expectorate, right? Not every morning, but every few days that happens, correct? So what happens to these patients' cilia? No, the tiny hair-like projections on their airway. they're destroyed or weakened, correct? So what happens to this patient's ability to clear their airway of this large amount and very thick mucus? It's harder to do that. So therefore, does this result in a chronic obstruction of these patients' airways? All right, so this is now responsible for the patient's manifestations. We'll get to that shortly. So these are the effect now of the smoking, or again, whatever pollutants this patient is exposed to. Multiply that by several months, years, or decades. This is what happens. So we cannot stop the increased mucus production, even if the patient's off work or is so therefore, the chronic inflammation results in the thickening of the wall of the airway, plus you add the increased mucus there. So what happens to the diameter of this patient's airway? Narrows, and then here now the results there, that's why they're prone to infections, is because this, remember, the cilia cannot propel it upward as efficiently as it used to. So therefore, any debris, so let's say you breathe in bird poop, dog poop, cat poop in the air, so they get stuck in this mucus, right? So what happens to all this debris? Can you get rid of it? Oh, they get stuck there, and then bacteria grows. Okay. So every now and then, especially during the fall season, these patients will have infections. Okay, so that's why we encourage flu and pneumonia vaccinations for these patients, because they're high risk for respiratory disorders. And they get exacerbations, they get attacks, and then we'll talk about treatment shortly. Let's go to, so this is the picture. So this is your normal diameter of your airway on the left. And look at now the diameter of the airway of an inflamed airway in someone with chronic bronchitis. So it narrows the lumen, making it really hard to breathe. It's hard to breathe in, even harder to breathe out. Let's go to emphysema. This one involves the lower airways now. So this will involve, let me show you the picture. This is now the area affected by emphysema. So the chronic bronchitis affects the upper large airways, and the emphysema affects the lower airways all the way to the alveoli, where the actual gas exchange occurs. So that is now emphysema. Now, most people who smoke have both. So they will have chronic bronchitis and or emphysema. Okay, so they get both conditions. So what happens in emphysema? So the patient here, let's talk about the normal physiology first. So none of us, are we breathing sterile air? Is our respiratory system therefore sterile? No, because you're breathing in poop, right? So you go out into the community, you go out into the river, for instance, and then you breathe, fresh air, but then there are microscopic particles of poop in the air, right? So we're breathing all of these in. No problem, because we have something called alpha-1 antitrypsin. Let me fast forward to that part. Okay, this one. This substance here is an enzyme that will destroy debris. So when we breathe in foreign particles, no problem. They get stuck in our upper and lower airway. We have alpha-1 antitrypsin. This enzyme has one job, which is to destroy debris. Whatever that debris is, pieces of wood, for instance, or nicotine, or any other chemical, if it's stuck in your airway, your body produces this and it will destroy whatever debris, keeping our air. Think of it as our own Clorox, okay, in our a natural Clorox. So it will kill and destroy foreign debris. So keeping our airways clear and clean. Okay. The problem again is if this patient is a smoker, what happens to the amount and number of alpha-1 antitrypsin that will be produced? It will increase or decrease? Why will it decrease? You're constantly smoking, so therefore you're constantly exposed to the pollutants. So therefore, what will happen to the amount of alpha-1 antitrypsin you will have? It will actually increase. Okay. Now, because you don't smoke 24/7, you have to go to sleep. So what happens during periods of sleep? You still have alpha-1 antitrypsin. What will this thing do? Still destroy something, right? But you're no longer smoking. There's no nicotine. There are no more pollutants left to destroy. What will they destroy? They have to destroy something. They were produced. I'm here. I have to destroy something. What will they destroy? They will destroy your lung structures now. So here in this picture here, so they start destroying the walls. So your alveoli are supposed to be individual grape-like structures like this. So when you have alpha-1 antitrypsin in excess, they will destroy those walls between them and making them one big consolidated blob. So are they still going to be as flexible as they used to? If they're now one big, no more. So here your lungs become large and flabby. Here they are now one big structure, and they are not capable of recoil to help you exhale. So that's why these patients with emphysema have a very hard time not only taking in a breath of air, but they even have a harder time getting air out. Because normally you and I, breathing is totally passive, right? These patients will now have to exert energy, effort, and accessory muscles just in order to exhale. Okay, that's how difficult it is for these patients to breathe. A small percentage, less than 10%, probably 1 or 2% of people with emphysema have never smoked, meaning they've never had first-hand, second-hand, or third-hand smoke at all. They lived a wonderful, disciplined life, clean air. However, they still develop emphysema. Now, in this small percentage of unfortunate people, they have a deficiency, a genetic deficiency of alpha-1 antitrypsin, meaning perfectly good people, okay, the never smoked in their life, work, in clean facilities, for instance, but yet they develop emphysema because the problem with them is they don't have alpha-1 antitrypsin. So therefore, what happens to their airway and lungs? Are they able to clean it? No. Okay, but that's only, again, a very small percentage of people with emphysema. Okay, just unfortunate people with that genetic deficiency. Any question between the two problems? Let me repeat, most people with COPD have both, because when you smoke, will it only affect the upper airway? No. So most smokers will have both chronic bronchitis and emphysema at the same time. Others may have one or the other, but smokers usually have both. Risk factors, we already mentioned. The number one risk factor is what? Smoking. Or again, if you are exposed to any air pollutants, certain toxins, then you're also at risk. So here's the list, chart 20-1. So smoking is number one. If you're not a smoker, maybe you are exposed to smoke, so that's secondhand smoking. Or it could also be third-hand smoking. When we say third-hand, that's the smoke and nicotine that sticks to smoker's skin on clothes, right? So if you're exposed to these, let's say you've seen people who smoke in their cars, but then leave the cigarette out with their arms like this. Does that mean their kids in the car are safe? Okay, so that's still exposing them to second or third hand smoking, all right? So increased age, air pollution, occupational exposure, as I mentioned. And then here's the genetic deficiency. But again, is this common or very rare? Okay, very small percentage of COPD patients with the genetic deficiency. Let's go to how are we going to diagnose the patient. Let's start with manifestations first. Now, just like heart failure, is this also a chronic condition? So will we ever see normal findings in these patients' respiratory assessment?
No.
No, they will have abnormal findings, just like heart failure patients. But, so which one are you worried about? The chronic changes or the acute changes? Okay, therefore, one of the questions on the exam is because these patients have abnormal findings, but they learn to live with these manifestations. So we only admit them to the hospital or make a change in their therapy if they're exhibiting acute symptoms. Are we clear? But you need to distinguish what is chronic and what is acute. Okay, so just like in heart failure patients, just like in chronic kidney disease patients. Okay. So let's start with the chronic. Now, there's no chart. It would have been good if there was a chart or a table, right? So you like charts and tables now? Miss Kalu, you still sticking with the same answer? No? Okay. So here you have to just look at the paragraph and then make your own notes, distinguish which ones are chronic and which ones are acute. So what about the this one's cough, sputum production, and dyspnea? Okay, these are chronic. Okay, of course, if and they worsen over time, if let's say, respiratory rate. So what was the respiratory rate for Miss Kindling this morning?
54.
No, her respiratory rate. But for others, it reached to 24, correct? Okay, so therefore, can you handle 24, breathing 24 a minute? Try breathing, so 24 a minute, that would be 6 breaths every 15 seconds, right? So try breathing, can you demonstrate? So I'll time, okay, 1. Are you okay?
No, you get lightheaded.
Yeah, okay. So it's difficult, right? With just 24. What about if it's 36 or 48?
That's the best.
Okay, can you last long with that?
No.
Okay, so that's pretty bad, right? So therefore, how will you know if it's acute or chronic? Okay, so the higher the respiratory rate, the worse. Okay, all right. And the amount and color of the sputum. What do you think is their day-to-day color and consistency of the sputum every day? No, the chronic one. No. Okay, either clear or white. Okay, and then of course that's large amount. However, when they get an infection, what will be the color of the sputum now? Now it's colorful. Okay, either yellow, green, orange, whatever color it is. Okay, anything other than white or clear, is it acute or chronic? Anything other than white or clear? Okay, that's acute. Is it reportable? Again, what do we report? The chronic or the acute? Okay, any acute manifestations need to be reported and requires a change or an addition to the current therapy. What about dyspnea? Well, they have a baseline dyspnea, meaning they will probably be in the high end of normal, let's say at least 20, but they're never less than 20. It could be 22, 24. It increases with activity, of course, because once you're active, you're exercising, walking, running, oxygen demand increases, correct? Can their narrow airways and those flabby alveoli meet that increased demand? No. Okay, of course, the dyspnea will increase. Why is there weight loss in these patients? Can you choose to breathe or eat? You have a choice? I'm tired of breathing. I'll eat.
No, it's hard for them to eat because they can't breathe.
Okay, so you can't breathe, you cannot eat, you cannot swallow, right? Because it'll be like this. So let's say you're short of breath. You go take a bite.
It's not aspirated.
And you do that. No. Okay, so either you breathe or you eat. Okay, you can't really, if you're short of breath, then there's no way you can eat.
What did they aspirate?
That's what I'm saying. So you either you eat or you breathe. Okay, there's really no choice for these patients. So they use up all so much energy and then not enough food in return. So that's why you notice you're in fourth semester now. You've seen COPD patients or any patient who receives bronchodilators. When do they schedule the nebulizer treatments? What times are they given?
Before breakfast.
It's usually 6, 11, 4, right? All before or after meals?
Before.
All before meals. Why? They need to increase the airway diameter to dilate bronchioles so that they can breathe better, they can eat better. Okay. Here's a change because of the, where's the, okay, because of this change here. So if instead of these shapes, your patients now have those hyperinflated and consolidated lumps of alveoli or air sacs, what happens to the size and diameter of the chest wall? Okay, they are now enlarged and they will have a barrel chest, barrel-sized chest, which is illustrated here. So this is now the diameter of the chest wall. See the difference? So on the left is normal, supposed to be oblong like this. Okay, the anterior posterior is shorter than the lateral or horizontal diameter. But look at now with the barrel chest, it's now almost a perfect circle. So that it decreases the surface area for lung expansion. Remember, the heart shares the same thoracic cavity, right? So there are only 3 structures inside your ribs, 1 heart and 2 lungs. So if that changes shape, that will affect the surface area for lung expansion. And of course, can this patient develop heart failure? Yes, because the heart is still in the middle. So if this patient has a flabby alveoli, no, the enlarged air sacs, increasing the lung residual volume. Residual volume is referring to the air left over after exhalation. So if the lung residuals are so high, so what happens to pressure in the pulmonary circulation? It increases. Which side of the heart pumps blood to the pulmonary arteries? Pumps blood to the pulmonary arteries. The right. So what type of heart failure will result here? Left or right side? Right-sided heart failure. This is a typical appearance. So these patients will have retractions here in the supraclavicular area because they'll be using a lot of those muscles with everyday breathing. Let's go now to systemic or extrapulmonary complications. So one is, or manifestations, one is the barrel chest. Another is, of course, the heart failure, which is a complication. Others are, they'll have polycythemia. What is polycythemia? Okay, they will have increase in red blood cells. Now, this is a compensatory response. What did you call the compensatory response to DKA? The respiratory? It was called Kussmaul's, right? This one, Polycythemia is the body's reaction to chronically low oxygen. Now, these patients, bone marrow will become hyperactive because the body is thinking, why is there very low oxygen? Maybe it's because I don't have enough red blood cells. So to compensate for that, the bone marrow will increase production of red blood cells. So you'll see polycythemia in these patients. So what happens to hemoglobin and hematocrit? It will increase. As a result, what will be the patient's color? They will be pink or even flushed. Okay, as a result, because you have so much red blood cells in your body. So they turn red or pink. Plus, what other problems will these patients have? So most likely, if you're a smoker, are you possibly a drinker also? Are you also obese? Are you also eating high cholesterol? So will COPD likely be this patient's only problem? So they, at the same time, they may also have heart disease, hypertension, diabetes, okay, or high cholesterol. Just like heart failure, we have class 1, 2, 3, and 4, correct? In New York New York Heart Association classification. This one, we call it a gold classification. There are also a gold 1, 2, 3, and 4, or class 1, 2, 3, and 4 in COPD. The higher the class, of course, the worse the patient will be. All of these are based on the patient's spirometry reading. Now, first of all, let me distinguish the word spirometric here, or spirometry. This is not the same as incentive spirometry, okay? What is an incentive spirometer? Yeah, that's what you use at the bedside, right? We have this small plastic device. You know what I'm saying? And you did this in fundamentals, right? You know how to use an incentive spirometer? Did I ask you this last week? How do we use an incentive spirometer? Go ahead, Luck. How do you, can you demonstrate? How do I inhale? Show me. It's too fast. Yeah. So you yawn into the device, okay? You yawn into it. How do you yawn? Do you yawn like, how do you yawn? So very slow and deep, right? So that's what you do. Exhale first and then you go. So you inhale over about 10 seconds, okay? That's how you use it. Very slow and very deep. How many times do we use it? How many times every hour? So that means every how many minutes do we use it? 6 times. No, sorry. No, it's not 6 times. It's 10 times every hour. So therefore every 6 minutes. Once every 6 minutes, okay? Do not let the patient use it more often than once every 6 minutes, because what will happen? Try doing that deep breathing consecutively. John, thanks for demonstrating. Inhale over 10 seconds, slow and deep. No. And then do it again right afterwards. How do you feel? Okay. So we don't tell the patient, do it 10 times consecutively. It should be once only every 6 minutes. Are we clear? How do we do it? Do they inhale or exhale into that thing? They. Here we go again. Please don't embarrass me. How do we do it? You inhale into it. Do inhale fast or slow? Slow, right? No need to hold. That's if you're taking a dry powder inhaler or a medication, okay? No holding your breath here. Are we clear? No holding your breath. Just breathe. After that, then they can exhale normally, all right? The objective is to expand the lungs, okay? So we'll get to the holding part, but that's for a medication, all right? Not for the incentive spirometer. This spirometry that they're talking about here is a bigger machine. You only see this in a clinic, not in the hospital, unless the clinic is in the hospital. So this is the spirometer. Here's the machine. No, it's not very clear. Here, this is the closest one. So this is it's a big machine, okay? So it will record, it has a hose, it has a mouthpiece. So the patient, here's the mouthpiece. The patient will be making a series of blowing, mostly blowing, and a few inhaling. So it will measure pulmonary, its official name is pulmonary function test. What does it measure? Well, a lot of things. One is forced vital capacity. It will measure residual volume. It will also measure total lung capacity. Now, to diagnose COPD, they will be asked to perform and measure the FEV1. This is referring to forced expiratory volume in 1 second. And as you can see here in the diagnostic, in the stages here, table 20-1, what do you see here? Is it the TLC or the FEV1? It's all FEV1 and FVC. So forced vital capacity is less than 70%, but most doctors will mention FEV1. Okay, so this measures the strength of the patient's lungs, strength of the patient's diaphragm. How much volume can they forcefully exhale in 1 second? So the patient will be doing this, a series of exhaling, of blowing into the mouthpiece. So they'll try first, okay, and then rest a bit, and then they'll inhale again, and then forcefully, and then they'll record the highest reading. To be fair, they'll record the highest reading. If the patient has FEV1 of less than or equal to 80% instead of 100, that's now grade 1. Look at what happens if they're now in grade 4. Only 30%. That means how much air is left in the lung after they forcefully exhale? 70%. So you understand how it's hard to breathe, even harder to exhale? Because there's a lot of old air left. Why can't they do this anymore? Why can't they get rid of most of the air in their lungs at the end of exhalation? Because of that flabby, those flabby alveoli. Okay, they're already destroyed. That's why they have the barrel chest. And again, John also mentioned about the airway, because the airway is also narrowed, so even harder to forcefully blow out the air. Any question about what these patients are undergoing to or experiencing? Okay, the changes in the upper and lower respiratory depends. It depends, because remember, we compensate, right? So yes, initially they may be in respiratory acidosis, but it's easily compensated. When they decompensate, just like heart failure patients, that's when they go into the ER, because they can't breathe anymore. And usually when they come into the ER because of the hyperventilation, what will you see in these ABG? Initially, you'll see respiratory alkalosis. Okay? But once they are compensated, you'll see usually compensated respiratory acidosis. Any question on the severity, the stages? All right, so grade 1 less than or equal to or greater than 80, and then it goes down from there, 50 to 79, 30, 49, and then less than 30 for grade 4. So where will you see grade 4 COPD patients? You see them outside here, walking around the city, or in hospice, or bedbound. Hey, these patients can they walk? No, not if they're only under 30% now. That means, just imagine though, what these patients are breathing like. Who has ever snorkeled here? Snorkel. How long have you snorkeled? I mean, when you go snorkeling, how long can you go?
Not long at all.
Why not? Why can't you? You have a tube. You're breathing through the tube. Why can't you snorkel for hours?
You get out of breath.
Why are you out of breath?
Because you're trying hard to breathe. So the
Okay.
energy that
Okay.
takes to breathe, you know?
Not really. Okay, so here, think about it. Let's say this is you, and this is your snorkel, right?
Yeah, like literally like.
Okay. So the first breath you took when you snorkel, what was in here? What is in here?
Yeah.
Yeah, what gases are there? There's 21% oxygen, right? 21% oxygen. When you exhale, what's in here?
Carbon.
CO2. So when you, the next breath you took, what did you breathe in?
CO2.
CO2 plus new air, right?
Yeah.
Imagine repeating that. So what happens? You are rebreathing CO2 each time. Now in CO2, in COPD patients, it's like having a really long snorkel. That's the effect. Imagine 30% only is what you're able to expectorate, to exhale every exhalation cycle. So if 70% of that is old air, you're rebreathing 70%, meaning 70% is left. So you're only replacing 30%. So how will this patient now sustain life or sustain any activity? Make sense? Okay, so this is what these patients are going through, and it's gonna be for life. All right, who are smokers here? Oh, you don't have to raise your hand, but if you do smoke, think about it. All right. So I watched my father, because my father smoked since 11 years old. I think he was 11. No, a different time. This was in, after the war. So it's like that, and I saw him. He still lived from. He's 60. Okay, he had COPD when he was 60. He didn't die until 81. So I saw him with COPD for 21 years. It was very painful to watch. Okay, everyday thing. Blah, just the amount of mucus he's having, and then he got strokes in between, heart attacks. So it's a hard life. All right, let's move on to complications. So we mentioned heart failure will result. So therefore, what are the manifestations? Is this right side or left side?
Right side.
Right side heart failure. Okay, so review the heart failure chapter. It'll be the same thing. However, we don't call it right side heart failure though. We call it cor pulmonale. Are we clear? So if the patient's right side heart failure results from COPD or any other chronic lung disorder, we call it cor pulmonale. Okay. That's the term. But if you take an X-ray, it'll look like any other right side heart failure patient. But what do we call it? Cor pulmonale. So I mentioned pneumonia earlier. Okay, they frequently get the flu, easily get pneumonia. They'll have chronic lung collapse because again, there's a lot of mucus in the airway. Those air sacs contain a lot of residual volume, a lot of mucus. Now they can also develop pneumothorax. We'll discuss pneumothorax next semester, but pneumothorax is air in the pleural area, in the pleural sac. Of course, there's air in your lungs, but this air is outside the lung. Okay, so this can collapse your lung also. treatment. Now, let's start with prevention and risk reduction. Is it too late to stop smoking? I've already smoked 50 years. Too late now. Yeah? No, never too late. So, and don't stop also, because whenever you speak to smokers and you tell them, it's really stop smoking, sir. They'll say, okay, thank you very much, but I like to smoke. All right. So don't give up. Okay. Keep talking to them each admission, because you'll get to know these patients. Because they'll be frequent flyers. Let's say you work in a med-surg floor or a tele or ICU, you'll see them again and again. All right. Same, because they even after they smoke, because they're already damaged, so you'll see them again and again. So don't stop. Keep doing your smoking cessation teaching. Okay, so you'll come a day, there'll be one day wherein they'll say, yes, I'm ready to stop smoking. All right. And then they'll relapse, but then, help them again. Okay. So eventually they'll be able to quit. Just like with my brother. Okay. I keep talking to my brother about our father, you know how he was, the strokes he had, and then he says, yeah, but it's easier said than done though. It's that hard. Okay, he's been smoking. My brother's 60 and he's been smoking for, I think, over 40 years already. Started smoking as a teenager. So it's not easy to quit. So smoking cessation is number one. And then we'll get to the, I'll skip the oxygen. Let me take you to the drugs first. The drugs is not in COPD because they're in asthma. Asthma and COPD have identical treatment. All right. So let me take you to asthma first. Go to medical management. All right, here are the drugs. Table 20-5. It's a long list. And these are forever, okay? So patients will either have a metered dose inhaler, a dry powder inhaler, or nebulizer. Or sometimes they'll be on all three forms. The rescue medications, these are emergency drugs. First one is albuterol. It also comes in levalbuterol or metoprolol. Most common one is albuterol, Ventolin. So this is for rescue, relief of acute symptoms. They are fast acting. However, they last short duration also. So these are your SABAs, short-acting bronchodilating agents. These are your side effects because this is a beta-2 adrenergic agonist. So therefore, it acts like a sympathetic drug. This is a sympathetic drug. So just like epinephrine, this will cause vasoconstriction and increased heart rate, just like epinephrine. So that's how it dilates the airways. Remember the airways, the picture we saw earlier? Why did the airway wall thicken? Because of inflammation, right? Because of vasodilation. So if you give a vasoconstricting agent, so it will constrict the blood vessels in the bronchial muscle. So if they constrict, that will thin the wall, right? But it will widen the airway. Are you picturing what I'm saying? Okay. But side effects again is tachycardia, palpitations. So it's again, any sympathomimetic agent. Next drug are your another short-acting ipratropium. So this one is a anticholinergic. What's side effect again of anticholinergic agents? So dry mouth. Can it also cause tachycardia? Yes, blurred vision, urinary retention. Okay. Although this is less systemic, but there is still some systemic absorption here. Although we give this in the airway only, supposed to be we expect local effects, right? But yes, there's some systemic absorption that occurs here. Any drug table or chart, what is the testable part? And patient teaching, so nursing considerations. Right. Okay, let's finish this quick. So ipratropium, and then now you have your steroids. Now, as you can see, short, is there, so we have inhaled, we also have oral steroids and IV steroids. Now, which form will be used depends on the patient's symptoms. Usually when they come in with acute symptoms, we'll put them on all three. Give them IV steroids. We also give them inhaled steroids. Please be responsible with the reading your nursing responsibilities. Okay, what to teach the patient. What will happen to sugar here? Increased blood glucose. What else? What happens to their susceptibility to infections? Okay. So whenever you use a steroid inhaler, what's your teaching? They should where? In the mouth, right? Yeah, so inspect the mouth. And what do you tell them to do after taking the steroid? Okay, perform oral hygiene. Symbicort, that's fluticasone. So yes, fluticasone is a steroid. Hey, let's continue. So here's fluticasone. So these are inhaled steroids. But these are now LABAs. Okay, these are long-acting bronchodilators. So what's your teaching with LABAs? Yes, but what else? What do you teach them to? How do we use these things? As needed?
No, every day.
Okay, so these are regularly taking with or without symptoms. Are we clear? Can they use this during an acute attack? This will be useless during an acute attack because there's no such thing as a rapid onset LABA. Okay, so they still reach for the SABA, so the albuterol or ipratropium, but for maintenance, it has to be regular. Okay, so your LABAs must be taken every day with or without symptoms. So we have LABA steroids. We also have non-steroid LABAs as well. Okay, so you'll see combinations. For instance, salmeterol is a long-acting bronchodilator. So think of it as a long-acting albuterol. They can be combined with a steroid. So let's say salmeterol can be combined with fluticasone, okay, in one dry powder inhaler. So that way you have the benefits of both a non-steroid and a steroid for long-acting relief. All right. I won't read all of them for you. This one's a tablet, only comes in a tablet, 10 milligrams for adults. Leukotriene modifiers is given to both asthma and COPD patients. The benefit of, sorry? This one?
Yeah.
Leukotriene, anti-leukotriene, yeah. So Montelukast is the, I've never really seen any other generic. So it's only Montelukast. This is Singular. Have you heard of Singular? This is Singular, okay, Montelukast. Sorry? Yeah, that's a tablet only.
It says tablets and granny.
All right, to make it easier for you, I will only be testing the 3 SABAs. And then for the LABA, focus on the first include theophylline because although this is an old drug, some doctors still prescribe theophylline, although not very popular anymore. But there are still old doctors out there, so they can still they'll still prescribe theophylline. So for the LABA, long term, all except the last okay, the last one is Montelukast. Right after Montelukast, you can disregard the others. They're not really very common. Right? So I'll test up to the leukotriene inhibitor or antagonist. Any question? Okay, let's go back. Any question?
Yeah. So albuterol.
Yeah, all three SABAs, and then for the LABA up until Montelukast.
Okay.
All right. Okay, let's go back to COPD. Let's talk about oxygen therapy this time. The smoking cessation, oxygen. What does it say here? What have you learned? COPD patients and oxygen therapy. What have you learned in fundamentals? I'm sure your instructors talked about COPD and oxygen. Okay, so that's kind of correct. Okay, when we give oxygen to COPD patients, remember they have altered gas levels now. So let's say they are grade 1, grade 2. So that means, do they have high CO2 levels?
Yes.
Yes. Okay. So you and me, we don't have COPD yet. What is our respiratory drive? What is our stimulant for breathing? Low oxygen levels or high CO2 levels? All right, and number one proof of that is, let's say you're here in my class. How soon before you start dozing off? Like you start, and then you yawn. Okay, so that means, what was the trigger? Why did you start yawning? You were not conscious, you were not aware, but your respiratory rate actually started to drop. Okay, because no, you listening to me, or let's say at home. Okay, so let's say for those who listen to the lectures, recorded lectures. So the more you listen, the more, oh, so boring, and then you start dozing off, and then your respiratory rate drops. So that means, what happens to your CO2 levels? They start to increase, and then your brain senses that, your brainstem senses that, oh, CO2 levels are rising. Let me give you a yawn. So the respiratory rate increases, starting with a nice long yawn. And then your respiratory rate goes to 12 to 20 again. So therefore, that's proof that our drive to breathe is high oxygen levels. So when your respiratory rate drops, CO2 levels rise, your respiratory rate increases. Now, in these COPD patients, what is their day-to-day CO2 levels? Already high. So will their brain still respond the same way? Will they therefore keep yawning all day? No. So their drive to breathe is now the other one, which is now the low oxygen level. So when their oxygen levels drop, then their respiratory rate rises. Make sense? So therefore, can we give them indiscriminate amounts of oxygen? Why? What will happen to these patients if you give them too much oxygen? they will stop breathing because there is no drive to breathe anymore. You messed it up. You gave them too much oxygen. So of course, is there still a need to breathe? No more. I don't need to breathe. Oxygen levels are so high. Does that make sense? Okay, so therefore, we only give them enough oxygen to what? What did you say, Miss Simon? To keep what? What is our parameter? What is our target? Okay, so as long as you get at least 90% or better, let me point you to the right here. So our goal is 90% or better. Once you hit 90, that's enough. Right? So what if, let's say, this patient has COPD and at 2 liters, the saturation was 86. What do? You increase it by how much? Okay, so you go to 4. Well, let's say you started at 3. It didn't change much. And then now you went to 4. At 4 liters, it was still 88. What do? Give them more. Increase it again. What's your goal again? 90%. Okay. So some doctors will say 88, but most doctors will say 90. Well, they'll write it and they'll say titrate to maintain oxygen at 90 or higher. So that means, did they specify how much oxygen to give?
No.
No, they simply said, give oxygen until what?
They're at 90.
Until you reach 90% or better. So don't be stingy with the oxygen. We know they have COPD, but right now, do they need it? Yes, they need that
So what
oxygen.
would you start?
Oh, of course, we don't want to give too much, right?
Yeah.
So therefore, will you start high or start low?
No. So what, we'll start with 2? Okay.
And then go from there. See first, how do they do on 2? Obviously, you're still at 80, low 80s. Okay, give them more. And then every 5 minutes, check. Keep going until they reach 90. And then later, let's say you were at 6 or 8 liters when they reach 90. Do we stay at 8 liters?
Yeah.
Wean them down too. Because you can titrate up, you can also titrate down. Because remember, we're giving steroids or other treatments. Okay, let's say they're here for pneumonia. You you treated the pneumonia. Of course, once they get better, they'll need less and less supplemental oxygen.
So then what if they hit the 90 and then you said you titrate?
Yeah, it's always trial and error. So a couple hours later, okay, let's see how you do on 6. Okay,
And
they
then
do
drop.
fine on 6. Yeah, drop them to 4, drop
No,
them
I'm
to
saying,
2.
what if it drops? What if it's like?
Oh,
drops
then
to
you
80?
keep increasing.
Okay, go
And
back up.
again, yeah, until you reach
90.
90 or better. So here again is the reason why we don't want to give too much oxygen. It will cause what? Okay, you will depress or decrease the respiratory drive, and then these patients will eventually stop breathing if you give too much oxygen. Are we clear? Any question about COPD and oxygen administration? Okay. So here, oxygen therapy is variable in COPD patients. What's our goal again? Which is what? Okay, 90% or better. So I won't repeat the pharmacologic. I already showed you. It's under where again? Where did you find it? Okay, under asthma, look at the individual and specific details on side effects and your nursing responsibilities for the drugs. So bronchodilators make up the bulk of the therapy. So we have inhaled and aerosolized nebulizers. We also have IV steroids. Most causes of hospital readmissions is not really because they're not getting enough treatment. I mean, these treatments that we're using, they're very effective. The problem is, are they using the inhalers correctly? Okay. If you take time to observe a patient, how they use their inhalers, you'll clearly see half of them don't know how to use it. Doctors assume that after one teaching, or the nurses assume, I showed you once, you'll be fine. No. These patients need constant teaching, okay? Constant reinforcement. Okay, show me each time, show me how you use your inhaler, right? We can look at the textbook, the description here on the steps. However, it's better if we watch a video. So let's look at first how we use a wet medication. I recommend this chick, right? Because if you follow the textbook and the step-by-step, this one is closest.
The cap from the inhaler. Shake the inhaler well for 5 seconds. Hold the inhaler firmly by placing your index finger on top of the canister and thumb on the bottom of the mouthpiece.
So this is a meter dose inhaler, okay? It's wet. It has a propellant. So when you press on the canister, it will spray the medication into your mouth and airway. Be patient.
Sit up straight or stand up. Tilt your head back slightly. Exhale away from the inhaler. Put the inhaler in your mouth. Grasp the inhaler and start breathing in at the same time. Take a slow and deep breath. Hold your breath for 10 seconds. Exhale.
This is where you hold your breath, okay? Up to 10 seconds. It doesn't have to be 10 seconds. I mean, let's say we'll put 50 pounds on this chick. Can she hold her breath for 10 seconds? No. Okay.
Now slowly through your mouth or nose.
Okay, and here repeat the steps. If another dose is required, they typically should wait. If it's the same drug that they're inhaling, you should wait about 1 to 2 minutes, meaning don't let the patient do this. And then, okay, that's not effective. So wait 1 minute at least between puffs. One puff, rest 1 minute, take the second puff. All right. Exactly. So that's why are they taking the drug correctly? Because can their lungs absorb it? That's the problem. Okay, they're in a hurry, and obviously were they taught correctly? No. So here's the warning if you Miss Morris. So if you're using a steroid, if there's a steroid in that inhaler, what do they do? Okay. All right. So let's go to the with spacer now, because the recommendation is spacer because as you can see, it required timing, correct? So if the patient doesn't have the dexterity, or let's say it's a very young or very old patient who don't have the correct dexterity, they won't get the medication because there's an incorrect timing. They go too late, right? Because the medications, once you spray, it's already in your mouth. What are you inhaling after it's already stuck to the mouth, right? So it has to be perfect timing when you go, right? Some people can't do that. So here's the recommendation for those people, again, very young kids, or just when in your observation, they can't, do the timing correctly, then recommend they use spacer. So this is the best way to use your meter dose inhaler.
Insert the inhaler into the open end of the chamber. Ensure that the inhaler fits properly.
So the medication will buy the patient a few extra seconds because it will circulate inside the chamber, allowing them to take their time to just take a slow and deep breath into their airway, inhaling the medication in. So you have, that's why it's called a spacer, because this will allow the drug to circulate inside the chamber.
Sit up straight or stand up. Tilt your head back slightly. Before starting to inhale, breathe out completely away from the spacer. Place the mouthpiece between your teeth and seal your lips tightly around it. Press the inhaler once, and then breathe in steadily and deeply.
See, there's no need for the
Hold your
timing.
breath for 10 seconds.
Okay, so they can just press
breathe
and
out
then
slowly.
breathe, take their time.
Repeat steps 3 to 10 after 30 seconds, if another dose is required.
All right, last one is a powder. So the first two you saw were wet medications. Okay, so they had a propellant, right? So this now, what if it's a dry powder? Dry powder inhalers do not have a propellant. I recommend this chick. Okay, so same company making all three videos, all accurate. So dry powder inhalers usually come in a disc. What the disc is,
Check the dose counter
Okay.
to see.
so this is the disc. The dry powders are in capsules inside the disc. So this will turn every time you cock when you turn this to activate a dose, it will turn the disc, exposing one capsule. And then you'll slide this trigger here, so that will pierce a hole in the capsule. And then now the powder is available for you to suck in. Again, this is not like the meter dose inhaler wherein you press the canister and it will spray. This doesn't have that. So you have to literally suck the powder in. Suck it in your mouth and deep into your airway. Okay, don't snort it though. You can't put the powder here and then, okay, no, you don't put a line and then snort the powder. Okay, there's not enough powder. Okay, this is a very small amount of powder. You need to inhale. Okay, you need to suck it into your into your airway as deep as possible. Just like the meter dose inhalers, they have dose counters, so you know exactly how many doses are left in the device, so that you can order ahead. So you're running short, order ahead, you pick it up. Okay, you never run out of these. So these are your LABAs. Okay, so earlier the SABA usually are your short acting. Okay, they come in a meter dose inhaler. LABAs usually come in powder.
See the number of doses remaining. Hold the inhaler properly in both the hands. Open the inhaler by using the thumb grip slide. You'll hear a click.
Okay, so that first click, turn the disc, exposing one capsule.
Hold the inhaler horizontally. For loading the dose, slide the lever.
Okay, so she slid the lever, the lever, it punctured one of the capsule, the exposed capsule, it punctured it right here in front of the mouthpiece. Now, the instruction said hold it horizontally because what will happen? It's powder. So if I tilt it downwards, what will happen? The powder will drop to the floor. Now you have no more medication, right? So hold it horizontally. Once you cock, hold it horizontally because again, you tip it, the powder will drop on the floor.
From left to right, you'll hear a click. Exhale away from the inhaler.
Now it's important, especially this one, not to inhale because if you exhale in front of the mouthpiece, what will happen? Or moisture can enter the canister, and then it will clump your, now when you exhale, you'll choke because now you have a clump of powder. It's now solid. So always exhale away. That way you don't moisten and clump the powder. Because you know how people, when they exhale wet. You notice that? Especially when sometimes I have students and then they're nervous and they get sprayed in clinical.
Place the mouthpiece in your mouth. Take equipment to right.
So the key here is quick and deep. Again, the objective is to get the powder, because what will powder do? It's dry powder. So if you don't inhale it deep, where's it gonna stick? It's gonna stick in your mouth. Do we want it in the mouth? We want it into your airways, deep into your lungs. So unless you really suck it in quick and deep, it won't reach your lungs, right? So this is what I'm saying by when patients take these, they just do this. Are they really inhaling it in the airway? It's in their mouth. Okay, so no wonder these patients get readmitted very frequently because they're not taking the medications properly. And whose job is it to teach them? That's you.
Hold your breath for 10 seconds. Exhale slowly through your mouth or nose.
And repeat again, at least 30 seconds to 1 minute for the next puff. Because it's usually 2 puffs. For cleaning the device. Okay. So the dry powder inhaler, the canister contained a liquid medication, right? So when you put the mouthpiece into your mouth and then you take it out, what's on the mouthpiece? Your good smelling saliva. It may smell good now, but 2 hours later, what's it gonna smell like? Like good morning, right? So it'll stink. So you wash the mouthpiece or the canister, okay, under soap and water, and then dry it. This one, can you wash this with soap and water? Why not? It's powder. So all the best you can do is, because you still put it in your mouth, so how do you keep it clean? You can wipe it with alcohol wipe. Okay, do not run it under water because you'll ruin the powder. Are we clear? Okay, but do clean it because this is good for a month. So if you keep putting in your mouth after a few times, what's it gonna smell like now? You still want to put it in your mouth? Yeah. All right, so that's your powder. There are modern ones now. Let me just show you. I don't know if it will be on the NCLEX, but we have breath-actuated PMDIs now. So these are modern high-tech MDIs. But these are going to help those, again, patients who have wrong timing. These things have a battery. These are battery powered because you don't need to, some of them you don't need to press a button. All you do is just to start breathing and then the device will spray the medication. That's why it's called breath actuated MDIs. Okay, so here's let's just watch it quick.
Grammarly's top 3 tips on starting an essay.
Let's say you're struggling to put pen to paper on an upcoming essay. You might have an out.
Asthma pumps or metered dose inhalers, MDIs, are often used in the mouth, but can also be used with a space placing 2 puffs into the air. Ensure that by placing your fingers on the grooves on the sides of the cap and gently pull the piece of puff by pushing down the dose release button, which is located at the back of the synchro breathe. Just below the dose counter. Close the cap. To release another puff, repeat this test fire process. Once 2 puffs have been released, your synchro breathe is now ready for use. Step 1. Shake and open. Shake your synchro breathe well while keeping the cap closed.
To do this, place your fingers on the sides of the body of the inhaler. Ensure that you shake and open. Shake your synchro breathe well while keeping the cap closed. To do this, place your fingers on the sides of the body of the inhaler. Ensure that your fingers are away from the cap and not touching the dose release button at the back. Open your synchro breathe by placing your fingers on the grooves on the sides of the cap and gently pull the cap down. Step 2. Breathe while sitting or standing. Hold your synchro breathe upright.
Breathe out normally, pushing out as much air from your lungs as possible through your mouth. Place the mouthpiece of the synchro breathe in your mouth between your teeth and close your lips around it, but do not bite it. Start breathing in slowly and deeply through the mouthpiece. The synchro breathe will automatically release a dose when you begin to breathe in from the mouthpiece.
Okay, so instead of the patient pressing and then the medication being sprayed, all they do, they're not pressing anything. All they did was hold this like this, and then the breath, the negative pressure, the vacuum that will be applied to the device because you're sucking in, right? Once you start sucking, it will spray the medication. Anyone using this for asthma or? Okay, so these are the newer MDIs now. They are called breath actuated MDIs. These are some variations. So the mouthpiece may not be in your mouth for the air chamber. So if you have a spacer, some of them are shaped like this. Okay, they go over the nose and the mouth. So it's not always just the mouth. So here's when the patients are having acute attacks, they usually, if it's mild, they'll stay home and then the doctor will increase the dose or add a steroid, for instance, to the therapy. But if the symptoms are severe, they'll be advised to come to the ER. I won't test the surgical management, but I'll just describe it. So let's say most of the patient's lungs are now those flabby alveoli, right? Useless, totally useless. How many lobes do we have on the right lung? 3. How many on the left? 2. Let's say one of those lobes have more of those flabby alveoli, meaning they're totally useless. They're just taking up space there. So do we need to keep that? They're useless. We can surgically remove it. So if the right lung has 3 lobes and that one lobe has more of those dead spaces, so we'll just remove it, giving that space to the other remaining lobes. Make sense? Practical, right? So we call those bulectomy. No, sorry, lobectomy. Or we can also remove those individual damaged clumps called bullae. Then you can remove the bullae. Call that bulectomy. Lung reduction surgery is the lobes that I mentioned earlier. So you can just remove one or more lobes and then give the rest of the space to the remaining lobes. Lung transplant is an option if you can get a donor. Nutrition, what type of diet will be encouraged in these patients? Remember, they can't eat much because they have to breathe. So what do you make sure that they're eating? That diet that because we don't know if they'll be able to take the next meal. This may be the only meal for the day. So this meal must contain what? It must be high calorie from what? Missed the So what should the nutrition be? Didn't specify, maybe it's under asthma. But the answer is high calorie, high protein. Okay, high calorie, high protein diet. Because they may, of course, we encourage also nutritional supplements, Ensure or Glucerna if they're diabetic. All right. Any question on COPD? Okay, return at 3:15.